Hi, good night. My name is Dr. Sisnet. I'm a third year dentist student and I'm a medical doctor. Tonight we're going to be talking about cements. Please note that I'm not an actual dentist, so therefore I cannot state that I'm an expert on this topic. I'm just basically trying to simplify cements for myself as well as for those who would like to hear how I've simplified it, and hopefully will give you gain some understanding about cements, and I myself would gain some more understanding about cements. So cements are used for three main reasons: luting, pulp protection, and restoration. So luting in itself is when an agent connects a tooth structure beneath to a fixed prosthesis above. So luting agents are actually used for fixed prosthesis, crowns, inlays, and onlays. So inlays are actually when you have an indirect restoration consisting of a solid substance which is fitted to a cavity within a tooth, while an onlay is the same as that, but it actually involves a replacement of a tooth cusp. So luting agents basically are strong adhesives. Pulp protection is required, for instance, when the a person or a tooth, there could be possibly mechanical, thermal, or chemical insult to the underlying pulp, resulting in discomfort or damage to the pulp, and which can result in devitalization of the pulp. So you need pulp protection to prevent this from happening. Restorations are used when a person's tooth has a cavity. You remove the carious lesion, and this carious lesion then needs to be replaced by a structure that prevents this defect from persisting, basically. Okay, so the principles of cements is that tooth and prosthesis themselves are rough. So what an adhesive such as a cement does is that it actually gets in between these crevices, and it then forms an interlocking or strong bonding with both the tooth and the prosthesis. This results in the fixture of the prosthesis to the area. So we've explained what is luting, we've explained what is pulp protection. Please excuse the typing error, and we've explained what is a restoration. So the principles of cements we will go into. First thing, let's just identify some of the cements that we will come into contact with, whether it be zinc phosphate. There's also zinc oxide eugenol, zinc polycarboxylate, there's glass ionomer cements, and there's resin modified glass ionomer composite cements, and there's also compomer and resin. Those are some of the cements that we're going to be talking about today. So what influences the choice of a cement? It can be the material of the cement, the setting time. Setting time refers to when the amount of time it takes from the time a material is actually mixed to when it's about to harden, while working time is from after you actually mix the cement, not before, after you've mixed the cement to when it becomes hardened. So setting time is from start to finish, while working time is after you've started to mix. So the consistency of the cement is also a deciding factor as to when, what, or if that cement would be used. So the types of luting cements, the cements that are used for sticking, the properties that you would require for these types of cement, this is just a list of the cements that we would use. But as I mentioned, the types of cements required for luting should have some certain properties, whether it be thermal and electrical insulation, resistance to displacement, resistance to fracture. Because remember, sometimes these cements are actually placed in areas where there's high compressive force. For instance, if you place a cement that has poor compressive strength in the occlusal area of the posterior teeth, this will result in that filling or cement being displaced because the cement itself does not have enough strength to withstand the occlusal pressures or strain of the posterior teeth. So therefore, some weak cements are actually used in the anterior teeth for that reason, because the anterior teeth, you do not exert as much power while biting as you would for the posterior teeth. So luting cements must also be hydrophobic and have decreased solubility, which makes sense because you don't want something that's actually used in the mouth to be soluble, because if you have saliva in your mouth, you drink water, you drink fluids, then it would dissolve. It must also be resistant to void formation. So that's very important, because when we say void formation, that means that, for instance, picture a a very small glass and you have filled it with a material, for instance soil, and versus cement, actual cement that you use to build bricks. If you fill it with soil, after a while soil tends to contract when the moisture has evaporated. Therefore you see that the contact between the glass and the soil would actually have been reduced depending on how dry the soil has gotten. So that actually creates a problem, because you don't want your filling to actually move away from the margins of the tooth of the cavity, because that can result in micro leakage. So you actually want the, for instance, like cement tends to expand, so you want it to be flush with the actual margins of the cavity, therefore preventing micro leakage and therefore preventing failure of such a cavity. So we just explained one of the properties of the luting cements. So the cements that we use for our luting, for example, there's one called glass right here, called glass ionomer cement. And this is a very good cement in the sense that it releases fluoride, which, as you know, has positive effects on the tooth. And the way how it works is that it bonds via chelation of the inorganic and the organic components of the tooth. So that's actually the way how it works. There's also resins which are used, resins seen here, which are based on 4-metal, and they bond via calcium within the tooth. So these are just two examples, but luting cements, it must be noted, set in approximately 10 minutes. So you don't have much time to actually mix and apply to the tooth. Now, as I mentioned before, those are just two of the luting cements that are available, whether it be the resin here and the glass ionomer cement. Now, I mentioned before that there's something called pulpal protection, because remember I said there's luting, pulpal protection, as well as restorations. So pulpal protection is very important. It protects the agents, protects against the pulpal irritation, whether it be from thermal or chemical or mechanical insults. So how do you protect the pulp? There are three separate subheadings that you must remember: varnishes, liners, and bases. So varnishes can be made of natural gum. So these consist of copal, rosin, synthetic resins. And when you're using them, it actually requires 2 layers. And how it works is that it forms a thin coat and therefore inhibits the passage of fluid into the marginal crevices, therefore it decreases pulpal irritation. So remember I was telling you that the cement actually works by getting into the crevices of the irregular crevices of both the tooth and the prosthesis. Now these varnishes work by getting into those crevices and forming a barrier, preventing any insulting agent from reaching the pulp itself. Another kind of pulpal protection is a liner. So the main ingredients in a liner will be calcium hydroxide, and the benefits of this is that calcium hydroxide in itself has antimicrobial, meaning that it functions to prevent bacterial growth. Now, it also has another benefit in that it produces secondary dentin. Now, if you remember from your oral histology and biochemistry, or histology and dental histology, that there are 3 types of dentin. There's primary, secondary, and tertiary. We already know what's primary dentin, which is laid down during the development of the tooth, but secondary dentin is produced after the root is completely formed, and growth produces a decrease in the size of the pulp chamber when we age, while tertiary dentin is produced in response to a stimulus, example caries. So this actually functions very well in the production of secondary dentin, and it can have some benefits to the person if it is used. Examples of liners would be zinc oxide eugenol, ZOE, or people abbreviate it as ZO, and there's also glass ionomer cements. There's also resin and MTA, which is mineral trioxide aggregate. Now there's also bases. This is also a subheading. This is the third and final subheading of pulpal protecting agents. Now these are applied as a thick layer. Now remember the varnishes were used as 2 layers and they form a thin coat, but the bases now they're applied as a thick layer. And examples of these bases would be zinc phosphate, Once again, zinc oxide eugenol, polycarboxylate right here, as well as glass ionomer cement. As you have noted already, zinc oxide eugenol, glass ionomer cement also is a liner. So bases and liners can actually overlap. Okay? So note well that some bases require a liner beneath them in itself. So zinc phosphate needs a liner as well too. So cements that are irritating to the pulp itself, remember these three: zinc phosphate, glass ionomer cement, and polycarboxylate. Those three are irritating to the actual pulp. Now we're going to our third and final heading for overall heading, because remember we've already done luting, we've already done pulp protection, but the last one is restorations. Now there are 4 subheadings of restorations that you have to remember. There's a temporary restoration, a short-term restoration, an intermediate restoration, and a long-term restoration. So a temporary restoration is on very short, while a short-term restoration is from days to weeks. Can be there from days to weeks, while an intermediate restoration can be from weeks to months, and a long-term restoration can be there for years. Zinc phosphate in itself, we're moving on now to the individual cements. So the first one we're going to be looking at is zinc phosphate, which comes as a liquid or a powder. 75% of the powder is zinc oxide, and the liquid is usually phosphoric acid, and it can be in the percentage of 38% to 75% phosphoric acid. The interesting thing about zinc phosphate is that it actually responds via an exothermic reaction. It gets extremely hot, and when the zinc oxide dissolves within the phosphoric acid, this reacts with another component within the powder called aluminum phosphate, and this produces zinc aluminum phosphate gel, and this in turn produces the set cement. So in the end, the cement consists of zinc oxide in a matrix, well, unreacted zinc oxide in a matrix itself. The setting time of zinc phosphate is 5 to 9 minutes. Once again, these things do not last so long that you can waste time if you're mixing them. The zinc phosphate must be, remember I said it consists or comprises of zinc oxide, but it reacts with phosphoric acid. So that's where the zinc phosphate comes from. It must be mixed on a glass slab, and it must be mixed via increments for 1.5 to 2 minutes. A spatula can be used to determine the readiness of the actual zinc phosphate. So for instance, if you use a spatula and you rub it and try to lift the spatula up, you should get, if you raise it about 12 millimeters, it's good for luting. If you raise it about 19 millimeters, it's good for cementing and prosthesis. It must be noted that zinc phosphate does not chemically bond to the tooth. There are some cements that actually bond to the tooth, but zinc phosphate is not one of those. It is done via the process that I told you, where it actually gets into the crevices of the individual, both the teeth as well as the prosthesis, and it creates like a very strong interlocking bond, so that prevents the prosthesis from moving. Zinc phosphate can be, the working time of zinc phosphate can be affected by remember this acronym, SIRS, SIRS. So spatulation, the increment size, the ratio of the powder to the liquid, as well as the slab coolness. So if you cool the slab, it actually slows the working time. The ratio of the powder to the liquid, if you adjust that, you can affect the working time. The increment size required for mixing can also be affected can also affect the working time, and the spatulation, the speed at which you move the spatula, can affect the working time. The next thing we're going to be looking at, the next cement, is zinc polycarboxylate. This, on the other hand, just like I just told you, the zinc phosphate does not chemically bond to the tooth. Zinc polycarboxylate does bond to the tooth, and it comprises zinc oxide, magnesium oxide, and tin oxide, plus polyacrylic acid and itaconic acid. Working time 6 to 9 minutes. Best to use a cool slab, which lengthens the working time of 2.5 minutes. And it is just like how zinc phosphate causes some irritation of the pulp, zinc polycarboxylate does cause mild pulp irritation. However, because remember I just told you that that the zinc oxide reacts with the polyacrylic acid, the acrylic molecules are actually larger in size. So therefore, remember that the zinc phosphate reacts with is the zinc oxide that reacts with the phosphoric acid. The phosphoric acid molecules are smaller than the polyacrylic acid molecules. So therefore, the polyacrylic acid molecules in the zinc polycarboxylate actually prevents the compound itself from entering the pulp as readily as the zinc phosphate would. And this is due to the size of the particles. Remember that the particles are larger to it, so therefore they cannot infiltrate as well as the smaller particles that are found in the phosphoric acid zinc oxide mix in zinc. The phosphoric acid zinc oxide mix that's found in zinc phosphate. So therefore it produces less irritation. So remember, zinc polycarboxylate has less irritation. The next thing we're going to be looking at is the GIC, as we call it, the glass ionomer cement. It's used for the anterior teeth, and it bonds via chelation of the carboxyl group of the acrylic acids to the calcium of the enamel dentin and dentin as well. To remember, I told you that the reason why some compounds are preferred for the anterior teeth is due to the fact that they cannot withstand the occlusal stresses or strains that occur in the posterior teeth, which is higher. So GIC tends to have it comprises silica alumina, sodium fluoride, aluminum fluoride, calcium fluoride, aluminum phosphate, and the liquid contains polyacrylic acid as well as itraconic tartic malic acid, okay, and water as well too. So it's mixed on paper. Remember the last two, which will be the zinc phosphate and the polycarboxylate. Those two are mixed on glass, but GIC is actually mixed on paper. Prior to placement, the tooth must be etched, meaning that the phosphoric acid must be actually placed on the tooth surface to create it, and this increases the energy of the surface and increases the surface area of the surface. Then that phosphoric acid, 34 to 37%, is then washed away. The area is dried, and the prosthesis or the filling is placed and covered with a plastic matrix for 5 minutes due to its sensitivity to air and water. This prosthesis, which will be the GIC, is then covered with a varnish initially to inhibit cracking and well, basically to inhibit cracking. Okay, so GIC in itself, like so many others, releases fluoride, which is good for the dentin and enamel. And the good thing about it is that it actually releases it over a long period. However, just like the other two I mentioned, GIC actually causes a lot of irritation of the pulp. So pulpal irritation is a major problem with GIC. So zinc polycarboxylate, zinc phosphate, and GIC cause pulpal irritation. The next thing we're going to be looking at is metal reinforced glass ionomer cement. So it's basically GIC with metallic fillers. It can be silver or particles of silver sintered to glass. Some brand names that you would think about: silver GIC is Admix or Miracle Mix, and particles of silver sintered to glass is Cermet. Okay, and it is used for cast crowns and primary teeth restorations, and it tends to be used in pediatrics or pediatric dentistry due to its rapid hardening. And that's kind of a common sense thing, because if it hardens quickly, it means that you'll be in and out of the patient's mouth very rapidly. So metal reinforced GIC is very good for periodontics and primary teeth restorations too, and it's due to its adhesions as well as fluoride release as well too, because it releases fluoride, and fluoride is beneficial to the patient's teeth. So that's a positive there. We're just going to talk about high viscosity GIC, which it includes atraumatic restorative treatment. There's prevention, restoration, smaller particles, and higher powder to liquid ratio, which produces a better compressive strength. Remember, compressive strength is basically the ability of a tooth to resist the forces required to make it smaller, while tensile strength is the ability of a molecule or a substance to resist the forces required to make it longer. So it's actually better than amalgam, and it is used for core buildup and as well as primary tooth filling. So both the metal reinforced and the high viscosity GIC or glass ionomer cements are used for primary teeth fillings. Next, we're going to talk about resin modified GIC, which can also be called a hybrid ionomer visible like cure glass ionomer, and it's made of fluoroaluminosilicate glass particles. It also has camphorquinone benzoyl peroxide, the component that is found in acne medication, as well as polymer I can't pronounce polymerization resin. Sorry. And the liquid it also contains a liquid, which so it comes in a powder and a liquid form, and the liquid form contains polyacrylic acid, water, methacrylic monomer hema, which is also known as hydroxyethyl methacrylate, and it's used as fissure sealants. Fissure sealants are used in the posterior teeth to prevent the formation of cavities in the crevices of persons who are either high or low risk, because some persons get them with, even though they are very good at maintaining good oral hygiene. So they're using fissure sealants, liners, adhesives for orthodontic brackets, bases and core build up as well too. So there's another form of GIC called calcium aluminum GIC, and is used as a luting agent. Remember, luting agents are used for sticking, and it comprises a powder and liquid form as well too. And the main component of the powder form is calcium aluminate, and the other component of it is strontium fluoride, as well as strontium fluoroaluminol, as well as polyacrylic acid. So the advantage of calcium aluminate GIC is that it has a decreased microleakage. Remember I told you prior to this that microleakage is when the cavity actually moves away from the margin. Food debris, saliva with bacteria actually gets stung into the crevices and creates a nidus for formation of secondary caries. So anything that prevents that from happening is good. So this actually decreases microleakage. It's biocompatible. It's stable in the long term, and it is of good strength and compressive strength. The working time is 2 minutes, and the working time is 2 minutes, and the setting time is 5 minutes. Right. So the last thing second last thing we're going to talk about is comprimers. We're just going to browse over it. Comprimers are basically, composite is better than comprimer, but does not contain fluoride. Composite is what they use for fillings. It tends to be tooth colored, and the benefit of it is that composites tend to be better than comprimer, as I mentioned, and they were previously used, or they are used currently more so than amalgam, which is a mercury-based filling, and they tend to be used for cavities because they are tooth colored. Therefore, they're cosmetically appealing. However, they're more expensive than the previously used amalgam. However, they don't have the mercury-based composition as amalgam, so the fear of the mercury-based amalgam is not there. So, comprimer is placed on low stress bearing areas. They release fluoride, just like less fluoride than GIC, glass ionomer cement. However, they release fluoride. There's less compressive and flexural strength due to the water uptake of comprimer. Comprimer is basically the equivalent of resin. So composites produce. Oh, I mentioned that the composites are better than composites better than comprimer. But however, remember that composite does not contain fluoride, while comprimer does. Comprimers can be light cured, chemically cured, dual cured, and resins use both light and chemical initiation to activate polymerization. So light cured means that you use the light to actually initiate the reaction to harden it. Dual cured means that it actually has both. It can both be hardened via light and chemical. Okay. So we've come to our last. Because we've already gone through proper protection, which would be the varnishes, liners, bases, as well as the types of restorations. So we've come to the final type of cement, which is resin. As mentioned before, it can the different types of curing, which should be chemical, light, and dual cure. Resins can be they can be cured via light and as well as chemicals within the actual compound, or they can be dual cured, and it's used to stick crowns, bridges, porcelain, orthodontic brackets. So there's a whole host of uses. So there's also another component, sorry, I missed one, which is called zinc oxide eugenol. It's a weak cement used for temporary fillings. Temporary fillings, as I mentioned before, there are different types. There's short-term, long-term, so it goes from days to weeks and weeks to months and months to years. So temporary fillings are used when, for instance, a procedure cannot be finished. So therefore, it a temporary filling is placed, and then you are able to come at a later date and complete your work. So there is a benefit of temporary fillings in that it seals dentinal tubules against the influx of oral fluids, and therefore also it produces a soothing effect. It's actually less irritating than most other cements. The reaction is slow but is more rapid if the area is warm and humid. And the setting time is 4 to 10 minutes. You are not supposed to place this directly on the pulp as it can produce tissue necrosis. As I mentioned before, it's a weak cement and it has bacteriostatic effects. So therefore inhibits bacterial production. If you would remember, what component did I say actually has bactericidal effects, which would be calcium hydroxide. Calcium hydroxide has bactericidal effects. There's also, now that I've mentioned calcium hydroxide, there's a component or a cement that actually has in calcium hydroxide. That cement is called mineral trioxide aggregate, and it contains calcium hydroxide, therefore it makes it antibacterial and antifungal. It's a good sealer, it's biocompatible. It takes 165 minutes for initial setting and 6 hours for a final setting. It comprises calcium oxide, aluminum oxide, and silicon dioxide. The calcium hydroxide can be placed